Good morning, and welcome to our November 2019 educational call of the Ohio Hospital Association's statewide sepsis initiative. I'm James Giuliano, and I serve as Vice President of Quality Programs at the Ohio Hospital Association. Today's program will address early recognition of deteriorating conditions, a very timely topic for us as we continue to decrease sepsis mortality throughout Ohio in both present upon admission and non-present upon admission encounters. Joining us on our call today are members of the OHA HIN, the OHA Statewide Sepsis Initiative, the Ohio Department of Health, the New Jersey Hospital Association, the Hospital and Health System Association of Pennsylvania, and Sepsis Alliance. Welcome to all. Please know that you will be given an opportunity to type in questions through the chat box feature throughout the presentation. You don't need to wait till the end. Questions, though, will be addressed at the end of the presentation. This presentation is being recorded and will be posted on our sepsis webpage, which can be visited at ohiohospitals.org/sepsis, and by clicking on the education link. There you will find all the previous recorded sessions that do not contain member data. This program has been approved for 1.0 contact hours of continuing nursing education. You will be provided with a link to an electronic evaluation tool. You will need to log on, complete the evaluation, and request your certificate. This evaluation process will remain open for 2 weeks following today's date. And if you have any questions on the process, please contact Dorothy Aldridge, and her email address is listed for you on the screen now. Lastly, we do encourage you to visit the OHA Sepsis website, which is a repository of resources, toolkits, and education. Now, I am honored to welcome Dr. Naeem Ali of the Ohio State University Wexner Medical Center. As Medical Director of the University Hospital, Dr. Ali is responsible for the oversight and supervision of patient care within University Hospital, including the inpatient units, observation units, surgical and procedural areas, and the emergency department. He received his medical degree from The Ohio State University. He is a pulmonologist and is board certified in critical care medicine and pulmonary disease. Dr. Ali, welcome.
Thank you, Jim. And to you and Dorothy, I really appreciate the assistance in getting the opportunity to present this today. So for your audience, I'd love to start this conversation by acknowledging that this is a presentation that's really focused on getting back to the basics of detection of sepsis. There's been a lot of confusion in this area with the introduction of new definitions and diagnoses, the way to diagnose. But I want to try to emphasize the story that we've had here at Ohio State University in terms of implementing a sepsis surveillance program, share with you both the highs and the lows, but our continual focus and emphasis on getting back to the basics. So with that, I will start off our conversation. This should be a slide and concept, a comparison that I think this group is highly familiar with, because I think if you're in the sepsis world at all, you are focused on the idea that sepsis is a time-critical disease. There are some common problems with respect to detecting and impacting outcomes of patients with time-critical disease, whether you're talking about STEMI, stroke, or sepsis. In the case of stroke and STEMIs, really robust systems have been developed to both recognize the clinical syndromes and to try to help people be aware of what those syndromes look like in the preclinical setting to bring them into healthcare. And I think once they're in healthcare, there's a separate marketing process and education process that allows us to deliver timely and effective care. Because with all time-critical diseases, the challenge is moving from vague symptoms and syndromes to actionable diseases and entities. This is not an easy process when you start to look at our current definition systems, and whether you're currently using a more SIRS-based or sepsis-based definition that's related to SIRS and altered physiology, or whether you're using a more quantitative QSOFA method of surveillance, the fundamental issues are the same, is that you're going from a profound syndrome that has the needle in the haystack is the significant disease amongst the wide range of folks that meet potential criteria. I want to illustrate, though, the power of and the impact and magnitude of understanding and driving down to coming up with a pragmatic definition. So I'm sharing with you historical data, partly because I wanted to emphasize the beginning of some of our processes, but this is an illustrative case that we used to kind of emphasize to our teams about what the value of simple recognition up front was. Now, the story here was this was in our emergency departments, which is obviously, I think, for most hospitals, the place where they begin with trying to create systems of surveillance around emergency department. It clearly does not end there, but in the emergency department being a common presenting area, we had implemented over the course of a couple of years with the use of obviously the emerging literature and physician champions, a sepsis alert in our emergency system and in our emergency department. And that sepsis system really relied on looking at the SIRS criteria and the suspicion of infection. It was it was integrated into all of our triage algorithms within the emergency department and led to, and this was an important marker for the clinical teams, an overhead alert that notified everyone that there was a sepsis patient in triage and that those patients would receive earlier and adopted care. So this was a high-profile intervention, and we wanted to look shortly after its implementation about how effective it was in identifying patients coming through our emergency department. So as you can see through this grid, it was a very specific alert. And I think what we learned from this was just using simple criteria at the point of triage, we identified real patients with sepsis. There's a hidden story, though, in that clinical suspicion in the emergency department. And again, I want to emphasize this was not facilitated with electronic tools. It was based on intake vital signs and clinical suspicion based on the description of the complaints of the patient was very specific in identifying. In fact, of the 412 patients alerted over this time period, 394 of them ultimately had the diagnosis of sepsis. The unfortunate piece you can see on the right hand of the slide is that this was the minority of patients. In fact, less than 20% of the patients that were diagnosed with sepsis were recognized this way. So a further 2,000 patients developed sepsis shortly after hospital admission. Now, clearly, this is a mixed group. It could be some that were actually septic in the emergency department but unrecognized with our screening tools, or patients who developed it shortly after presentation. Either one are a concern globally for that alert. And so this raised the question to our providers, and their comment to us was, so what? And part of the so what related to, as emphasized in the program, the recognition of a sepsis alert led to the early administration of antibiotics. When we looked at process measures, there clearly was a difference in impact, right? 89% of those patients who had a sepsis alert up front received antibiotics in the appropriate time window, whereas only 25% of the other patient group did. Now, when you looked further after hospital admission, the numbers bore out even more concerningly. So even though patients got into a healthcare system, and remember that continuum of time critical disease being the delays are largely felt to be related to patients recognizing their own deterioration and then getting into healthcare. But looking at that box on the right-hand side of the screen, these are patients that were under our care, and really only a fraction, only barely 70% of those patients received antibiotics in a timely fashion, so suggesting that our recognition is partial. So, and in fact, if you look at it, overall mortality was improved, obviously associated with that early antibiotic administration. And if you were recognized as a sepsis alert at the initial presentation, you also had a significantly reduced mortality. So suggesting that there were some holes in our screening system in the emergency department. Now, this slide may emphasize a current concern that many of you may be experiencing right now, which is essentially the overall syndrome of sepsis and how it differs from STEMI and stroke. So what this data and what this table reflects is if we take our model and our work from STEMI and stroke, There is a lot of work in that. First of all, the magnitude of cases annually in sepsis, as you all know, is proportionately much higher. So we see many more patients of that. And when we see many more patients, we see a lot more diversity and variety. You can also see, I've tried to break down all three of these syndromes into the general accepted prevalence of disease in terms of patient populations being community acquired or in hospital acquired. And I don't mean that as in we gave it to them, but I do mean when does the syndrome present? Because this is a common concern that we often have. Some of those missed cases may not have actually looked septic in the emergency department, but developed sepsis on day 4. That is as much of a recognition problem as it is at the front door of the emergency department with the same outcome differences. And I think the thing that I like to emphasize here is that when you look at these percentages, while the magnitude of the percent changes aren't that dramatic, around 5% of all patients presenting with stroke, only about 5% of them presenting generally in the inpatient setting, 95% really presenting from the community, and similarly for STEMI. In sepsis, while that proportion more than doubles, that is a really dramatic increase in the number of cases. It's twice as more common for sepsis to occur in hospital than the other time-sensitive syndromes. And from a magnitude standpoint, almost 4 times as many patients. So it's a big problem. So whatever success you've learned in the emergency department, if you leave it at the emergency department's door, you're missing a significant proportion of patients with sepsis. So the next step is really, how do you introduce that into the hospital environment? So let me just get back to this to kind of talk, and what we'll be getting into is something beyond sepsis screening in the emergency department, but I want to complete this story of other observations that we were considering. And what this extension of that original ED screening story is really about is how do we expand to make our screening tools smarter so that we can focus the clinical intuition, which is really the sepsis alert in its basic format. How do we focus that clinical intuition a little bit more broadly to consider the patient who doesn't come in complaining of infectious symptoms to identify them? So this is the previous history. What we decided to do after this was to look at the potential for adding a threshold Muse score. Now I'll get into what Muse scores are, but in general for this discussion, it was taking those initial intake vital signs and instead of looking at yes, no for SIRS, doing an integrated calculation of a weighted analysis with a published integrated physiologic screening tool that generates a score based on vital signs and mental status that defines a threshold. And we picked a threshold greater than 3 because in our patient population, it recognized more patients and had, but it didn't identify everyone, which is obviously a concern with universal SIRS screening. And what we found is that by only screening with Muse for a score of greater than 3, again, an objective number without clinical intuition, ultimately we identified more than twice as many patients with sepsis presenting through the emergency department. Now the downside is we almost measured 10 times more patients who needed to be screened. So this will raise a significant concern when you get into the inpatient environment where you don't have a 3 to 4 hour exposure of patient care, where you have days and days of patient care because the volume of alerts now becomes a question and a problem. So this is the reason why then translating these lessons learned from the emergency department into the inpatient setting becomes so critical. And I highlight what literature do we look for. Historically, there had been obviously literature looking at how to detect sepsis, but where we've typically gotten our surveillance, our ideas about how to modify our surveillance processes, were really in the MET literature, the medical emergency team. In our institution, it's called a rapid response team. But these teams, or early recognition team, these teams, which are generally nursing and advanced provider-based teams, are not in a ratio of, they're in a high ratio of patient to provider, but they are generally designed and appear to detect sepsis in almost up to half to a third of the patients that they screen and identify. So this is kind of an entity distribution amongst a prospective study of MET calls and found that really 50 to 60% of those patients were sepsis. In fact, in delayed ERT calls, sepsis was even slightly more prevalent, suggesting that obviously there may be more need for objective screening in this. So the MET literature, or the rapid response team literature, for me has been the guidepost for how to implement effective screening tools when you're trying to find patients with sepsis. So let's break this down. So once you've got a long horizon of clinical exposure to a patient, how do you determine medical deterioration? Because that's really what we're all here to learn about and to try to improve. And again, these are concepts that I believe you've tread these paths in your institutions, almost universally. It's just how you process through improvement that's really the point of this presentation. So obviously medical deterioration is a little bit like the characterization of how do you identify pornography. I know when I see it, but it's hard to quantify. Medical deterioration is similar in that same way, in that it's unexpected clinical worsening due to a natural history of the disease, or in the case of nosocomial-acquired complications, an unanticipated new ailment. And really, the standard has been based on monitoring physiology. So one of the problems with this is that you get multiple potential failure modes when you start looking at the interpretation of multiple clinical signs. So some of those, the physiology, the current vital signs, and the trajectory may be monitoring dependent. They may be related to how many vital signs are displayed for you in your electronic medical record at any given time. Can your provider narrow the screen that they view from 24 hours to 8 hours? Can they expand it to 72 hours? That type of view and the flexibility in doing that may alter your team's ability to monitor trends. Some of it, however, is also experience dependent, and we all deal with clinical healthcare environments that have varied level of experience of providers who are in those surveillance positions. So this is two major separate domains that need to be addressed. So most of the literature suggests that medical emergency teams rely on systems of vital sign surveillance to help identify and recognize deterioration, and then use that clinical intuition applied to determine what the cause of the deterioration is. Some of those events are still missed, and that's a concern. And sometimes folks kind of reference the fact that they don't have kind of the smart monitoring technology or the right monitors. Regardless of the reason, and I just want to use this to anchor kind of our responses here, doesn't matter why you're delayed in recognizing clinical deterioration, the impact is significant. And most prospective observations of and retrospective reviews of MET calls suggest that about 1 in 5 of events are recognized much later than they would be clinically. So the good news is 4 out of 5 times we recognize things immediately, but it's that 20% of the time that things are a concern. When that occurs, obviously outcomes are much worse, whether it's mortality or other more subjective outcomes are worse. But when you look at the trigger criteria, so we'll get into this a little bit later, but obviously MET teams have either narrow or diffuse screening call criteria. When you look at timely calls are as a proportion of the events. The bedside nurse is more often calling about concerns of global concern about deterioration, not a specific vital sign. When the specific vital signs are used, more often those are triggers for late recognition. So in the delayed recognition group, single monitor values were more often a trigger, and global intuition and concern. And that could be because of the experience of the provider or the general inability to put the picture together clinically. So, and as I suggested, those delayed calls were associated with increased mortality over time, even after adjustment for clinical characteristics. So really our monitoring dilemma is that we need to look at numbers, but how can we be smarter than those numbers? And I believe that that's focused on an approach that balances universal screening with numbers, with an approach that identifies target and rich patient populations. And so that's what we're going to talk about as we move forward. So what are those patients? When we've, pulled our MET team groups together to talk through what are the big concerns you have, these are, generally speaking, these are those risks that staff talks about. These are those categories of criteria. And I think the one thing to emphasize is that staff concern is one of the most problematic to implement, and I think that staff concern can be augmented by the use of the objective criteria above. So in other words, if the goal that we have is to tune our clinical providers to having the right level of concern, the numbers can help drive us there. So what we attempted to do with translating sepsis screening with a Muse component into our inpatient units was a focus on a Muse Plus that's focused on patients undergoing transitions of care or appear to have clinical deterioration. So we looked at post-op patients, post-ICU transfer patients, new patients who were admitted to the floor, and notably those who had not been admitted to the floor with antibiotics as worthy of kind of an informal patient population to focus on. So that was how we broached this. Our background was we knew in our hospital, as illustrated on this slide, that for patients who transit through our ICUs, we see a whole heck of a lot of sepsis. So we know that those patients are ending up in our ICUs, and how do we detect them earlier? This was data that we pulled out about the DRG 870 and 871 that really characterized at that time kind of our best estimate of who are our sepsis patients. And we recognize that we do have a high volume of these, and almost every one of these patients, only a third of these patients land in our ICU directly. 2/3 of them are coming through our general floors. So we made this part of a process improvement goal to improve our early recognition of deteriorating patients, focused on the implementation of a Muse process. I'm trying to illustrate for you how we implemented that. So, we tried to work through saying what was our usual process of screening for vital signs, assign general responsibilities for a primary physician, bedside nurse, and our responding ERT or MET team nurse. And then we tried to introduce the addition of this Muse population. And again, what we felt like was we had teams that were adequately educated, but we needed something to focus their attention, so let's try to use that Muse. And again, trying to reduce the signal-to-noise ratio. I said that I would describe what the Muse was about. The Muse score is a synthetic score that adds a point value to multiple domains of vital signs, from blood pressure, pulse, and respiratory rate, to temperature and more AVPU demonstration or validation of the level of alertness, and assigns a point score. And again, we responded to those scores of greater than 30. The idea here was, how do you create noise in the lower left-hand corner of vital signs that are bouncing around without direct trend, and turn that into a Muse score? So the graphic here is an illustrative example of some deep dive on on a specific ERT case that ultimately resulted in an ICU transfer. So on each of the graphics, on the x-axis, 0 represents the time of the recognition of need to transfer to the ICU. So every hour negative from that is the leading time. And what you can see in the bottom graphic is heart rate, respiratory rate, temperature, and blood pressure are moving, but not in unison and not in similar directions. However, when you translate that into the Muse score, you can see an upward trend. We picked a trigger of a change of more than 2 point scores in Muse, or an absolute value of 3 or higher to identify, but either one of those trajectories would have identified the patient 10 hours earlier. We then worked with our EMR to make sure that there was an appropriate place to document that. So that allowed for people to use global views of the practice to identify and track trends, created thresholds where there'd be highlights to draw practitioners' attention. And we also then had a detailed breakdown, as you can see in the bottom half of this screen. These are screenshots from our EMR, which happens to be Epic, but where it breaks down where you're getting the points from and how is that characterized. Now, one clinical problem we had at the beginning is that we can use the EMR to generate these numbers, but we needed someone to say that all of these numbers were collected at a reasonably appropriate point in time. In other words, we may have measured their vital signs at 2 o'clock in the morning, but we may be looking at their mental status now at 3 o'clock in the morning. And is it reasonable to associate all those vital signs together? So we did build as part of this, and this is a graphic, a teaching tool that illustrates how we want the bedside nurse, again, having a specific responsibility of validating that all those vital signs are associated together. So we created not only the Muse score, but a validated Muse score that pulled and said, as a clinician, this is the current state of this patient. And then it was that number that we used to trigger our response. Well, as with everything, we had to do education of our bedside nurses to make sure that they were actually doing the work to validate that. So we created what you're seeing on the screen now, process reports that allowed us, and you can see by the date and by the unit, to look at the number of patients that were there for a full 24 hours. And you can imagine that if we asked nurses to validate that several times a day, we could come up with saying, okay, on unit D3 at the top, they were validating 1 Muse value per 24 hours. If our policy said something different, we knew that we needed to go in and do education in those units. And that allowed us also to look at cultural adoption. So for all of those of you who implement across broad systems, I think you can relate to the idea that when you put a practice in place, some units adopt it well and some units choose to ignore it. Here's an example of, and I'm not calling out this unit or this hospital for having low adoption of Muse, but our Ross Hospital is our collection of inpatient beds that were focused on cardiac care. And the cardiac care patients and the high prevalence of tachycardia was a clinical group and entity that had the least amount of buy-in in terms of following SIRS criteria. So from the very beginning, they were very low adopters of having their nurses validate Muse scores, and therefore the average number of Muse scores validated per patient was much lower in our Ross Heart Hospital than the other more general cancer hospitals or general medical surgical hospitals. And we use that to kind of translate forward and then say, what kind of culture of escalation do we have in each of our hospitals? So this is our count of medical emergency team responses over time. And we noticed that there were significantly fewer medical emergency team or rapid recognition team calls in our business unit that did not validate Muse consistently. And so this led to us at the end of this interval really trying to dive deep into the Ross's clinical culture and clinical patient population to try to identify a trigger that made more sense for them. So, you know, in general, what I would say is that by adding this, we learned a lot about our clinical environment as a whole, but what did we learn about sepsis outcomes? So in that same interval, we implemented the outcome that or the process that I just described, a sort of combined surveillance between bedside nursing and our local physicians, and with a surveillance by adding Muse scores for looking for patients with sepsis. And then over 4 weeks, tried to identify whether we are improving outcomes. Prior to this pilot I'm going to demonstrate for you, we did also we had to think about what are you doing when a score is greater than 3? What actions are we looking for? And this is where our policy discussion came to a consensus around what do we do at Muse scores of 1, 2, and 3. We probably leave it up to escalation to the charge nurse at a score of 3. We make sure we're involving the primary responsible clinical team at a score of 4. And an ERT is considered at a level of 4, but at a 5 or higher, it's recommended and or mandatory. So, and in addition, the bedside clinical team was to be trying to identify what else should they be doing. And it was in this context with that recommendation after implementing that grid of how to with respect to a Muse score that we saw these outcomes. And this outcome was related actually to a pilot slightly earlier than this, but was our demonstration outcome group, where we took the same progressive care unit and looked for the prevalence of sepsis, prevalence of ERT calls with the implementation of a Muse screening system, and the occurrence of ICU transfers. So what we did see was that in general with the 2011 pilot, the rate of ICU transfer was significantly less In addition, with respect to outcome of sepsis patients, we did see beneficial trends in the mortality of those patients who were found to have either sepsis or at the time severe sepsis, and also trends towards improvement in outcome with those patients who've experienced an ERT, suggesting that we were looking in a better haystack than we were previously. Not every one of those patients was a needle, but we found we were focusing in on the right patient group, reducing the overall after adjustment, even though the raw numbers weren't clinically significant. After an adjusted analysis, it clearly improved mortality in those patients in this pre-post pilot, very simple design. So we did learn that Muse could add value as a hotspot indicator, that in this case, it did require a dedicated team to really respond to the synthetic score in order to add more appropriate local response. But it couldn't be automatic. We still had a high number of Muse scores that were elevated, and we had to deal with patients who had syndromes that persistently elevated their Muse score related to a single vital signs that was dramatically out of normal. So we knew the work couldn't stop there. And currently, while we still use Muse, we're introducing other versions to help us improve the specificity while maintaining good sensitivity. So we had adopted Muse as a sepsis-specific tool, but still didn't have universal buy-in. So what should that trigger be? I've suggested that we're moving beyond the simple Muse scores alone, and I want to just go through a potpourri of other options when it comes down to what are your triggers to have clinicians apply kind of their qualitative thinking about whether a patient has sepsis or not, and what do those look like in the published literature. So obviously single values are inherently less relevant, or less expansive in their net, but I will suggest that in our practice, what we have been grossly concerned with is our response to patients with respiratory rate abnormalities. So in other words, this is from the published literature from 2008, and really just said looking at specific driving syndromes, respiratory distress or hypotension, what this outcome illustrates is that in general, respiratory distress, even in hospitals with highly evolved MET teams, it took a lot longer for respiratory distress alone to bring attention to a patient on the floor relative to patients with hypotension. It took 5 hours for hypotension to get recognized and escalated to an ERT team, rather than the 12 hours it took for respiratory distress. And it again may be that low blood pressure is much more actionable. It's much more precise what to do about it. Respiratory rate has a lot of other drivers, but it's still a clinical concern. And one of those, if I were going to take a single vital sign and make it the most important to pursue, first would be temperature, but second might be respiratory rate. Clearly there are other drivers, and that's a qualitative judgment on my part, but I would say that respiratory distress is one of those that people have normalized a wide range of abnormalities and perhaps under-recognized more significantly. There are exciting new emerging data. This happens to be data from patients at Ohio State and from an investigator here, but in collaboration with an industry lab device. But what they looked at is something that's attempting to get more specific. And what these investigators looked at was most of your automated lab devices that measure cell counts also do automated assessments or electronic differentials. They also can measure cell size. And so what this scatter plot really is it's a graphical version of the size of different populations of cells, or that volume distribution. And what they're highlighting here is that if you look at the data from these devices, you can identify populations of lymphocytes, neutrophils, monocytes, and also their relative size. Now, they use that size characteristic to compare to prediction of sepsis. So in samples of blood taken from patients with suspected infection who either turned out to have sepsis or not, the predictive ability or the ability to discriminate patients with sepsis was significantly improved, not only if you looked at white blood cell count, but white blood cell count and also the size of the monocytes in that white blood cell count. So the idea being is that looking at a lab-specific value that is available real time can help your screening and augmentation. Now, this is a graphic that's probably too small to see unless you're really close to your screen. But what it is it's a surveillance of all the different ways, all the different triggers for MET teams. And the point here, I'll have you look at the top set, which really looks at pulse, respiratory rate, blood pressure, temperature, and then other reduced sets. The Criticos criteria are simply limited to high pulse rate, high respiratory rate, and low blood pressure. A more simplified version, but one that's been tested against others. Now, when you compare this to an integrated screening, a series of any individual values are negative, to things like Muse, in this case it's called the News, what you do gain, generally speaking, is improvements in specificity. So the graphic in the upper left suggests that by using general systems, your sensitivity is just as high, but it's much less specific. And so by moving to these integrated systems, you can improve specificity. And I asked the question in the lower right-hand corner, what's your trigger? The trigger rate is 20% of patients. Is alerting on 20% of patients in your clinical environment tolerable? If it's not, as it's not in our environment, given resource limitations, how do you get to a more precise signal? And I think these last couple of slides are really about the direction we're moving. And one exciting area, what I've talked about with MET and ERT criteria, are really generic for medical deterioration. In the area of sepsis-specific triggers, think about the value that we're starting to see with the big data analyses. So this is from a study led out of the Emory Center for Critical Care and Tim Buckman, where they used machine learning to take a wide range of variables that are available in your EMR and both do a training and development set and validation set to determine what criteria are, what elements are available in your EMR that can be used to predict sepsis. And here's an example of how this expands the net beyond vital signs and beyond clinical intuition into vital signs, laboratory values, changes in respiratory rate, variation in respiratory rate, laboratory values like blood gases, and demographics. What's the location of the patient? Should our triggers change whether you're in ICU or whether you're in a med-surg floor? How about the specialty that you're being cared for? Are there certain things that surgeons recognize that are different about the manifestations of sepsis because they're a post-operative patient? And these are all things that are helping to advance our understanding about it. Now, using this broader array of tools, a risk score was developed called the AISE score. And what I've got illustrated here is a similar graphic about signal to noise. So the bottom panel are clinical events. The the middle panel are the raw vital signs of heart rate, blood pressure, mean arterial pressure, respiratory rate, et cetera. The thick green line is the AISE score. This ends with the blood culture positive on the far right-hand side of the top panel at the very end of the interval. Shortly before those intervals, antibiotics were started and blood cultures were drawn. The SEP3 threshold was reached shortly before those blood cultures and antibiotics were reached. But look at the AISE score. A full 6 to 12 hours prior to the SEP3 criteria being met, or an official time zero, your teams were given up to 12 hours of lead time if the AISE score had been a trigger. So it's an illustration of how by using more data and learning and validating that information, the EMR can help us. Is it currently doing that? No, but that's the hope. The overall area under the curve for prediction was very good, not in the excellent discrimination range, but really identified a large number of patients without too much false positivity. The prediction and discrimination was about 85%. So it showed some promise there. So what are the other ways we can promise? I've got a couple of slides here talking about what we think are the target groups. This is illustrated from critical care ICU outreach teams. This was a study from the UK that helped us to understand that another target patient population are patients who are discharged from the ICU to the general floor. In these patients, they created an ICU outreach team that followed these patients. And this slide shows to you what kinds of interventions they did. A lot of it was related to respiratory toilet, performing chest physiotherapy, patient repositioning, follow-up on medications, tracheostomy management. Again, highlighting that idea that post-ICU recovery and respiratory rates and other problems are a concern. In their group, when they created this ICU outreach team, they did improve outcomes by maintaining good survival to discharge, and although the p-value was close to 0.05, it did significantly improve survival to hospital discharge, but dramatically reduced the need for ICU readmission, improving outcomes. So that's also what we've considered an important target patient population. Another emerging area that I believe will add to our screening with tools is the idea of frailty. This is an article out of the geriatric literature that really suggested that age is just a number. Again, getting smarter than the numbers. If you just look at the age of patients, and this is in an elderly patient population, survival to hospital discharge could be explained by age, with older age being at risk for higher mortality. But if you fold it in and replace that with a score of frailty, you described a much wider range of outcomes. In other words, a 97-year-old with low scores of frailty, so they're resilient, has a much better survival than a 65-year-old with high frailty. Now, what does frailty mean is illustrated on this next slide. This is a common tool used to measure frailty, and it's a lot of things that we already measure in our EMR. How many hands are going up if I asked you to raise your hand if your nursing documentation includes assessment of whether the patient needs help with bathing, dressing, or up with chair, or whether your occupational therapists are getting around to a high proportion of patients to measure these values. So you can get a sense of where the patient risk might be informed by this frailty measure. So when you put it all together, and I'm kind of wrapping up right now, what we've taken from this is that we do need to be smarter than the numbers. That sepsis recognition starts with recognizing the medically deteriorating patient. It then evolves with an identification of what are the target patient populations, what are the skill sets of the clinicians in those areas, what do they already detect well, and what do they need help with, and to be cognizant of the resources needed to implement any of these systems. You have to ultimately focus on a broad screening tool with a special attention and focus on specific patients. In our group, we've looked at transfers out of the ICU, post-op patients, and ED admissions, patients newly admitted from the ED who do not have antibiotic therapy, in addition to that, to apply the Muse screen and to look for sepsis cases. And when you can, try to evolve and add a sepsis screen. Now, what I will say is for those of you who are currently using Epic has attempted to develop their own homegrown tool that we are starting to pilot and try to use. Some of you may be doing this. Some of you may be waiting for more information to be gleaned around it. We're willing to be guinea pigs here at Ohio State, so we're attempting to try to see how this augments our Muse view to get more specific about sepsis. Now, the interesting thing is similar to the machine learning process where experts pulled out values, Epic did this with a different domain. And in fact, what I'm excited about is that they have included a number of things around documentation of certain other elements in their of other treatments being used and medications, which I've not seen used in other areas. So putting the risk score in context with the treatments. And with using that kind of score, we generate a different number. Muse generated by a sum of physiologic changes, but this sepsis now being from a bunch of documentation and other comorbidities. And really what we've had to do, and what the point that we're at now, is combining, as you can see, the Muse risk score with the risk of sepsis in the predictive model. And then from that team, launching our ERT teams, launching our sepsis order sets, and trying to improve therapy. It does require a big team to put all this together. As you can see, we have to work out a workflow, just like we did with the Muse implementation, about how to integrate Muse and this sepsis score. What's our trigger threshold? And hopefully, if you come back in 6 to 12 months' time and I speak with you, I'll be able to tell you how the results are looking. But we're at the point now where, just like we had to validate Muse scores, we're now getting in with the bedside nurses and helping them to learn, validate, and respond to these new inputs of Muse and a sepsis risk score. So with that, I'd like to leave you with the idea that really systematic screening is the most pragmatic way of helping to identify the medically deteriorating patients. Specific variables are much less relevant, I believe, than integrated scores, but your access to which integrated score depends on the EMR you're working with and the clinical teams you're working on. The best way to narrow your trigger rate is to start to target sepsis-rich patients, populations, whether that's based on clinical characteristics like frailty or other characteristics like post-operative state or transitions of care. Is up to you in understanding your own institutional environment. You got to understand your institution's threshold and willingness for taking on capacity for new clinical work. So in environments where there's little wiggle room, focusing on much more enriched patient populations is the way to go. Institutions that are committed to hitting this on a much broader scale may choose different strategies. Know your teams and what they need, because the worst thing about surveillance is when you're telling others that they're missing something, so you have to be cognizant of how to deliver that message. And most specifically, monitor your case rate and monitor the outcomes. It's the only way you're going to know whether you're fishing in the right pond. And with that, I'll pause, and I think we'll take some questions, but thank you for the time and the opportunity.
Well, thank you, Dr. Ali. And at this time, we do invite participants to continue to submit any questions that you may have through the chat box feature. We will be reading them in the order that they're received. Also, I would like to remind you that it's not too late to submit questions. So even as we're reading them, if you do have questions, we'll be happy to read them aloud. So, Dr. Ali, thank you so much for a wonderful presentation. You really hit on some major key points for recognition of deterioration. So I'll get right to the questions that we have submitted. The first one is, how do you address the hesitation to administer a broad-spectrum antibiotic because of a concern for antimicrobial stewardship?
That's a great question. You know, I think this is one where we've had to, some people may not like my characterization, but sometimes it's friends close and enemies closer. I will say that they are, on the surface, appear to be diametrically opposed concepts. I think it gets back down to, so first one pragmatic thing, if you have a formal ASP team, they have to be part of your programming and planning for sepsis screening, because there has to almost be the validation and approval to give broad antibiotics when every other message sent through the healthcare system is to eliminate unnecessary antibiotics. And that's where really the target-rich patient population coming to identify those together is really key. So I didn't comment on this before, but I have found in practice that our ASP is in general resistant to us giving early empiric antibiotics in a broad group of patients until we get into the details. Because that same ASP team also recognizes that certain comorbidities, let's say neutropenia from chemotherapy, say excessive risk due to high-dose immunosuppressives in a transplant patient population, or a steroid-dependent COPDer, does change that risk threshold. And so when you get down to specifics of the patient population that you're looking to target, so if you were looking for a narrow place to start where there's consensus, the patient population coming in on high-dose steroids who exhibits changes in physiology is one where empiric antibiotics feels more comfortable to the ASP pharmacist, our lead infectious disease doctors. And so the pairing generally that can build is the sepsis team starts the antibiotics and the ASP team holds people accountable to making sure they're de-escalating when they don't validate that suspicion. And it's a good partnership, but a great question focused on the specificity and the number of triggers that are being launched.
Thank you. We did have two questions that came in that deal with the issue of predictive analytics. So I'm going to read both of them to you. And the first one is, you showed a vital sign trending. Do you feel that predictive analytic applications to EMRs are effective to invest in? And the second one is, have you started implementation of the early deterioration scoring within EPIC to use in conjunction with or independent of the sepsis predictive analytics? And I can repeat those if you need me to.
I can address that. I think both that it brings up an important point. It is important for me to raise this one issue that it's unclear as an institution how we would have responded if EPIC wasn't developing a sepsis-specific tool. So I will tell you that our first role was to identify what is the one synthetic score that we want to implement. I put Muse scores not in the category of predictive analytics. I put predictive analytics in kind of more of the box of delicate informatics genius. You know, if I can't do it with simple math and a scoring tool, then it must be predictive analytics. And I think that's a working man's definition and is reasonable. Would we have gone the route of moving into predictive analytics if we didn't have a vendor who was already trying to develop it and learn something about it? The answer is a strong maybe. Personally, I feel that predictive analytics is a way to automate clinical intuition. And there are other ways that we can, in other words, if I didn't have access to a predictive analytics tool, either an add-on software or kind of a continuous monocyte distribution with display, what I would be doing is finding where the bank is. If I'm going to rob the bank, I got to find it. So I got to find those patients at risk. I would be adding in layers of, okay, we've got a frailty score documented in the EMR. Let's use that to focus our efforts, and let's apply Muse and clinical intuition and chart screening in this smaller patient population. Having said that, that is, that's like pink unicorns and purple sky world stuff, because in reality, we're all faced with turnover of staff, the problems of education and learning, and it may be that the cost spent in a predictive analytics outweighs the residual training costs and the ongoing maintenance. But right now, I don't think that there's any consensus screening tool that has such an ROI that you can justify jumping into it. So for us, we're at a beta phase. For Tim Buckman and the machine learning process, I think they're just doing that from the internal, from the abilities they have internally, and we haven't chosen to go to an outside vendor or add-on analytics tool, if that answers the question.
Thank you. Our next question is, you mentioned experience-dependent and monitoring-dependent clinical signs. What is the most effective way to assist newer clinicians to gain experience in recognizing these signs?
Well, I think the answer is we all educate all of our clinicians. Every job position has an onboarding plan, has an orientation. Every unit, I'll just use the language of our nursing units, has kind of annual competency fairs and annual competency checkoffs. Our residents and our staff physicians have quality and process measures they have to attend to. This is where I think the best thing that we can do for those patients is, or for those staff members who are new or may have an education learning curve that they have to kind of climb, is to be very specific about the target-enriched populations. So the more clear we can be that, hey, if you're newly admitted from the emergency department and you don't have an antibiotic already on board, and oh, by the way, our ED is only finding about 1 in 4 of our patients who are ultimately septic in the first 24 hours with their best of their efforts, that's a place to go. So that you add artificial constructs that you can teach those folks. And instead of saying, go with your gut, say, go to the patient who's coming from the OR, go to the patient who's coming from the ICU, go to the patient that's coming from the ED without antibiotics, and now take a deeper look. That doesn't mean treat them with broad antibiotics, but it means go spend your time phenotyping those patients. It doesn't eliminate the learning curve, but it accelerates it. And I think that's what most managers have responded positively to, is that don't look at all your patients and learn something about sepsis. Look at these patients and learn something about hidden sepsis.
Thank you. Another question that came in, I think this deals with the issue of frailty. The question is, we want to proactively screen elderly patients. What age would you suggest we begin with, 70 or 75?
Or younger.
Yeah, so that sounds to me like you're getting into, so I should declare that my expertise is not in geriatrics. I will say that generally speaking, when I look at the literature and the geriatric literature, obviously the minimum, they don't tend to describe below 65, but I see most literature starting at 75 and higher. But again, I would echo what I think came out of the last slide. I'm not sure that that the number alone, there may be a threshold in when you might want to apply the frailty score, and I'd have to get back to that literature to decide where they feel like it's valid. The elements that they're describing, the activities of daily living, to me, felt like they describe frailty at any age. What I'm not as familiar with is how frailty is measured and whether that's considered valid in younger patients. But from the start of it, you know, I'd say obviously in the 70 and older, but I'd have to look at those tools more specifically, and I admit some ignorance in that area.
Okay, next question is, as a physician, what strategy or tactic do you recommend for escalating concern for clinical deterioration that is ignored or downplayed once escalated as a staff concern?
Yeah, so this is a real culture question, I think, and it does kind of come down to what kind of systems of oversight do you have. You know, we've you know, I work in a hospital where we've had a constant, one generic challenge that's been on our radar for the last half dozen years that I know of, and probably longer, is what's our clinical chain of command? And how you answer that question will inform the response. From my standpoint, we have had resistance to treatment in those areas, and our response has been to add a more robust chain of command. That happens to have included us engaging, it took a couple of years, but starting to engage all of our unit medical directors, one, to make sure that there was an appropriate leader on each unit that felt comfortable responding to patient escalations, to creating a parallel escalation pathway that not only was the traditional, you know, first responder, whether that's a trainee or an APP or a covering partner, to then the ultimate attending physician, through to their supervisor or their clinical chief, and then ultimately up to a department chair, and then CMO if necessary. What we've added to that is a parallel pathway of somebody who's considered local, who's considered a respected peer that occurs in that local medical director domain. So medical directors 10 years ago didn't really involve themselves in patient care issues. They talked more about process globally. We changed that responsibility for them, creating a more local, friendly contact that the nursing team felt more comfortable escalating to, and that's who we use to resolve those. If it can't be resolved locally, then it moves up the quality chain depending on the severity of the discrepancy and the concern. And but again, it's a huge marker of culture. No matter how good your culture is, you'll always get pushback on this. And how you respond to that is really probably more indicative of how you handle escalation in non-sepsis cases. But again, by creating that peer network, I'll say as the medical director of the hospital, I try to call about these concerns as infrequently as possible, but as often as necessary, by having people who are closer to peers, who it doesn't feel like the principal's office calling is a good baseline system. And then over time, when you need to escalate by calling from the principal's office, there's a little bit more recognition. And it also is softened by the fact that the initial interventions are all one-timers that the clinical team can unwind if they don't feel are appropriate when they get more fully engaged after that escalation.
Well, Dr. Ali, thank you so much for your time and your expertise today. Certainly, this has been extremely helpful, and I know I speak for our cohort when I tell you that we have learned so much today and have had many considerations put forth. Thank you again for your time, and thank you to all of our attendees for joining us today. As a reminder, there is no webcast in the month of December, but please do plan to join us again on Wednesday, January 15th in 2020 for our next webcast beginning promptly at 11:30 a.m. Finally, thank you for all that you do to decrease sepsis mortality each and every day throughout Ohio. This concludes today's call. Have a great day.